Welcome to the May Coffee with a Clinician. I'm Clayton Powers, and I'll be facilitating today's discussion. I'm a doctor of physical therapy specializing in the care of individuals with complex health conditions, and also I'm the education liaison at Bateman Horne Center. Before we begin, we want to thank the donors whose support makes our community programs like this possible. For this session, Dr. Todd Davenport and Staci Stevens from Workwell Foundation will discuss Section 5 in Chapter 4 of the Clinical Care Guide titled Post-Exertional Malaise Objective Testing. We'll discuss different ways that PEM can be objectively measured. We'll also discuss the history of the two-day Cardiopulmonary Exercise Test, or CPET, and how the two-day CPET has been used to identify PEM, the pros and cons of the two-day CPET, what the test looks like and feels like, and answer other questions that participants have written in the Q&A feature. As a reminder, we cannot provide medical advice. So I'm super excited to be able to introduce our panelists. Dr. Todd Davenport is a doctor of physical therapy, researcher, professor, and chair in the Department of Physical Therapy at the University of the Pacific in Stockton, California. Dr. Davenport's research interests primarily relate to understanding the clinical presentation and underlying physiology of post-exertional neuroimmune exhaustion in ME. Staci Stevens holds a master's degree in exercise physiology, and she founded the Workwell Foundation to help patients obtain objective evidence of post-exertional malaise for disability purposes and to research how exercise contributes to PEM. And Staci has lived experience with ME since 1989. All right, well, thank you so much for joining us. And you can go ahead and share your slides, and then we'll answer questions and have a discussion after you present some slides.
That sounds great. Thank you. I just want to start by saying thank you to the Bateman Horne Center for hosting us. What a privilege to be able to speak with you today, and thank you all for making the time and carving out the energy to attend this talk. I have my coffee, my version of electrolytes, ready to go here. So taking coffee with a clinician, the clinician has coffee. So here's hoping that you can enjoy that which you can on your end. So without further ado, Staci and I were asked to go over just a few key concepts related to cardiopulmonary exercise testing, and we were never really sure the experience and knowledge level of the folks attending, and we don't want to make any assumptions. We don't want to load up that knowledge cannon and shoot it right over people's heads. So it's always good to start with some of the basics. So if it seems a little slow at first, I promise it'll pick up. And then so I'll lead this first piece, and of course invite Staci to chime in. We're partners in this, and so it's important that we both have a role in it. So what is cardiopulmonary exercise testing? Well, it's been around since about 1920, which I'm not very good at math, and I was not a history major, but that's a really long time. This is a tool that's been around in biomedicine, widely used, widely studied for a very long time. CPET, as it's affectionately called, is defined as a non-invasive diagnostic procedure analyzing responses and cooperation of the heart, circulation, respiration, and metabolism during increasing physical loading or muscular stress. And so there are a couple of things that are really important about CPET that drop out of this definition. The first is non-invasive. Now, we're going to talk about one form of CPET. There are some forms of CPET that you can get invasive in a hurry, but for our purposes today, we're talking about a form of CPET that is done by analyzing breath. So it doesn't require introducing, catheters and electrodes, and doesn't require blood draws and so forth. So non-invasive is key. It also, the other thing that's important that drops out of this definition is that it analyzes both the responses and the multi-systemic cooperation of the muscles, the heart, the lungs. And so here we've got a modality that could be very useful, is often very useful for diagnosis, in addition to characterizing a person's function. So we know how hard a person is able to work at predefined, pre-specified levels of workload. So we can extrapolate that to, the amount of exertion a person can tolerate in their daily life. So that's the functional characterization piece. But we also have a very rich data set from analyzing the heart, the lungs, and the muscles to answer key questions like, what is the state of your nervous system during exercise? What energy system or substrate was your body using in order to fuel the exercise? How well was your body using the oxygen that it was taking in during the exercise? So again, we can map all of that data and calculate many different kind of measures and variables based on that very basic data in order to map it onto specific disease states. So not only is CPET important for characterizing function, which is true, and something that was identified in the NIH's toolbox for ME/CFS, but it's also great at helping to identify both the presence and severity of end organ diseases. Again, CPET both as diagnostic modality as well as a way to characterize function.
Hey Todd, can you flip this to presentation mode?
Yeah.
There we go.
Oh, but it's yeah, there.
Yeah, yes, no, yes.
Looks great.
Woohoo! Thank you. Okay. So this is what you should have been looking at. I don't know what you were looking at before, but that was the slide that I spent an hour putting together. So again, CPET, end organ disease, as well as functional characterization. All right, moving on. Here's what it looks like. There's Staci on the left, Jared Stevens on the right, who's our clinical coordinator and tech extraordinaire. You have, just to kind of point out a few items here, you've got the bike. This is an electronically braked bike that allows the task to get harder as you go forward in the task. The subject here is wearing a special mask with a gas collecting device and tube. And the gas tube eventually filters all the way down into this device underneath the computers, which you might be tempted to think is the computer hard drive, but that is called a metabolic cart. And that metabolic cart has a gas analyzer in it, which permits us to be able to analyze the composition of oxygen and carbon dioxide in every breath, which then gets filtered through the computer. You'll also notice some additional things. There's EKG, so we have electrocardiogram set up here on our participant so that we can monitor EKG throughout, both for safety reasons as well as probably the most valid way to measure exercise heart rates. We're also measuring blood pressure, systolic and diastolic, doing that manually, the good old-fashioned way here, using a blood pressure cuff and a stethoscope. And so this just kind of gives you an idea of the setup. And again, this is carefully monitored. This is not a thing that we're asking somebody to walk for 6 minutes, and hoping for the best. There's a lot of care that kind of goes into this whole setup. The reason that this is important is one of the key insights, and Staci's really been the innovator and the leader here, is a single cardiopulmonary exercise test gets you only so far. You can do some pre-testing, you'll have that cardiopulmonary exercise test. You might do some kind of a post test. You might ask somebody how they feel and so forth. But you don't have another physiological test positioned when a person is experiencing PEM. And so again, the idea here is that you have to have that second test positioned during the post-exertional state in order to really understand the physiology of the post-exertional state. So this is where the 2-day CPET comes in. So after the maximal CPET, 24 hours later, of course, Staci's been doing this for 30 years, and I've been doing this for somewhat less time than that. And we've experimented with different lengths of time. 24 hours seems to be the feasible sweet spot. Do a second maximal CPET 24 hours later, and that allows you to appreciate differences before and after inducing post-exertional malaise using the first test. Why a maximal CPET to induce that post-exertional malaise? Well, it's a standardized exercise challenge, meaning that we're only going as hard as your body can go, and we're not keeping you at that maximal level of exertion for very long. And so even though maximal is in the name, as it turns out, the overall workload turns out to be less than submaximal tasks that you might do for longer. And so, the test itself lasts 8 to 10 minutes. Sometimes a little more, sometimes a little less, depending on ability. And so, again, we're not keeping you at that maximal level of exertion for very long. Certainly not the whole time. This is a ramped protocol, working people up to that criteria for maximum. So again, positioning that second CPET allows us to characterize the post-exertional state, the biology of the post-exertional state, in an objective way instead of through surveys, which as we all know are fraught at best to really help us characterize post-exertional malaise. We're at that simple that we could throw a survey at it and be able to identify it based on a questionnaire. So there are some important things that we've come to understand from CPET. And the first is that your kind of rests on this idea that your body has a couple of different energy systems that it uses to fuel your daily functions. And so it functions a little like a plug-in hybrid car. So a plug-in hybrid car has a gas motor and it has a battery. And that battery is really good for stop and go traffic. It's good for tooling around town, lower speeds. The gas motor generally is good for hauling people in gear, going up and down hills and so forth. So these longer term, higher torque types of activities. And the gas motor charges the battery. Well, in people with ME/CFS, that long-term energy system we found, aerobic energy system, is impaired. And we found that because people have an early onset of anaerobic metabolism. So people tend to leave aerobic metabolism earlier than normal, and they tend to use a compensatory, less efficient strategy instead in the post-exertional state. And we learned that through 2-day CPET. So that's the first important thing that has dropped out of 2-day CPET. And the second important thing that has dropped out of 2-day CPET is this idea of payback, this idea of post-exertional malaise as a lot of things, but one of the things that it is impaired recovery, an impaired recovery response. And so we use the credit card analogy to talk about that, where credit limits and interest rates tend to differ across individuals with ME/CFS versus those who are deconditioned versus those who are fit. So if you were to walk up the stairs, let's just say one of my students were to walk up the stairs, they would probably bound up the stairs 2 at a time. They would get to the top, not lose their breath at all. And so they have put, that activity on their energy credit card, and they're able to pay it off instantly. High limit, practically no interest rate. The payback is instant. Now, if I go up those stairs, I'm going to take them one at a time. Might use the handrail because could use hitting the gym a little more. And I might have to pause at the top because I've lost my breath if it's a lot of stairs. So I've put a little bit more on my card compared to my limit. My limit is lower. and it takes me a little bit to pay that back. So my interest rate is a little bit higher. Well, in a person with ME/CFS, negotiating those stairs, even walking to the bathroom, even sitting up in bed, can make you exceed your credit limit. So you have a very low limit and a very high interest rate. So it takes a long time to pay that activity back. And so here again, one of the things that we have learned through 2-day CPET is the impaired recovery response associated with post-exertional malaise. And we have learned, that is really sort of part and parcel, and maybe even part of the defining um, characteristic of this key aspect of the illness. So again, if impaired recovery is an issue, this was something that we talk about a lot in terms of what happens after the CPET. And this is late breaking data actually from a poster that's going to be presented at the American College of Sports Medicine by Anthony Nguyen, who's a undergraduate student who's working with us. And Anthony's going to be presenting on recovery after 2-day CPET and using the data set from Betsy Keller's cohort, Maureen Hansen's cohort, that was published in 2024. Fantastic paper. And so this is a secondary analysis of that cohort, just looking at the time it takes to recover to self-reported baseline. There's some concern about there's some obvious and justified concern about how long it takes. And so what we found is that there's about 10% that take beyond about 3 weeks, but 90% of at least participants in this study were recovered within 3 weeks. So the expectation is that the vast majority of people, virtually all people, should recover within about 3 weeks. But within that 3-week cohort, we also found some important differences. About half of that 3-week cohort recovered between 1 and 3 weeks, and about half of that cohort, a little over half of that cohort, recovered within a week. And in fact, the median was 5 days, which is a faster, which is a fast recovery. And so we think that there are two different cohorts. There's a slow recovery cohort, and there's a fast recovery cohort. And so one of the things that we're doing now, in the manner of building on our understanding of 2-day CPET, is trying to understand the underlying physiology and the signs and symptoms associated with these fast and slow recovery groups, with the idea that 2-day CPET might even be used to stratify folks for clinical trials based on their recovery dynamics as another marker of the severity of the illness. We're also working on a few other things, in terms of just understanding that we're never going to get away from exertion. It's in the name. Post-exertional malaise is in the name. We're never getting away from that. And so now, how do we manage that? How do we improve participation in clinical trials for very severe individuals who may not be able to travel for or tolerate a CPET? We're looking at the lowest level of stimulus, repeatable stimulus, that we can use to objectively characterize the biology of the post-exertional state. So we've got a couple of grants trying to look into what's called the metabolic reflex, which is essentially detecting the instant in time that your body's heart rate and blood pressure start to increase in response to circulating exercise metabolites. And so that involves a hand grip task, standardized hand grip tasks. You may have heard of hand grip as an exertion. This is a way to standardize that. I mean, there's some issues and problems, of course, with using hand grip as a maximal hand grip as a measurement, but we think we've come upon a way that we can standardize that and deploy that. And so that's another thing that we're doing to try and identify a little bit more the potential role for exertion, but using exertional levels that might permit better inclusion. So with that, I'm going to pause and ask Staci to add to, respond, retract, dispute, tell me that my slides ain't working.
They work great. Fantastic, Todd. Looks good.
All right. Well, um, Clayton, that's what we
Yeah,
had in
great.
the way of the formal program.
Awesome. Yeah, we have some great questions on here, and then also I have some other questions I want to ask you, but we'll make sure to get to some of the questions from the Q&A. I first wanted to ask you, Staci, can you walk us through how you discovered a long time ago that this effect from CPET, where if you do two in a row,
Yeah,
that
long,
there's
long
this
ago.
effect?
Yeah, so in the 90s, there was a clinical trial that used a 1-day CPET as an outcome measure. And I was talking to the patients that were undergoing this 1-day CPET. And after patient, I was asking them, how long did it take you to recover? And what was your experience? And I think, that's sort of been the foundation for what we do. The patient experience is really what's important. And I was so concerned because I just thought we're measuring the wrong day. We're missing the most important symptom, post-exertional malaise, right? Or neuroimmune exhaustion. At the time of that study in the 90s, they were using the Holmes criteria, which you may or may not be familiar with because it was a long time ago. It didn't even require post-exertional malaise as a criteria. But all of our patients had it, and all of their physicians said the patients in the study were disabled. And I thought we're just missing the boat. And I think that's the reason clinical trials aren't successful, is because they don't measure patients in PEM, which is the most disabling symptom. And so I thought, well, I don't think I can reproduce a cardiopulmonary exercise test. And what's so significant about that is it's highly reproducible in heart disease, in lung disease, in HIV, in all of the conditions except for PEM. And so I jumped on a bike, went to the University of the Pacific, to the lab, jumped on the bike, did a test. 24 hours later, came back and did another test, and my results were not the same. And at that time, I had no intention of having anybody else ever do this. I just needed to prove to myself that there's something wrong in PEM. And it wasn't possible, and yet that's what it was. And so patients started asking me, how can I get my disability? They were all being denied because at that time, chronic fatigue syndrome wasn't real, it was psychological, and there were no objective measures. Everybody was getting denied. And I said, there's one thing you could do, and this is it. And so that's how it started.
Thank you for sharing. And how do you decide now, um, which people are appropriate and which, like the pros and cons of doing it?
Yeah, it's always about risks and benefits. So sadly, 30 years later, we still don't have a diagnostic test for the illness. Patients are still not believed. Nobody is believed. So doctors don't believe it's real. Family members don't believe it's real. And so there's this huge disbelief. But if you have a cardiopulmonary exercise test and things are abnormal, you can't fake the ability to use oxygen to produce energy. These are numbers that you cannot volitionally change from day to day. And so it's really validating. In the beginning, we had a lot of patients just coming because they weren't validated. They thought they were crazy. If enough people tell you you're lazy and crazy for years and years and years, you start to believe it, even if your doctor gives you a diagnosis. And so it's really validating. So the risk versus benefits, yes, there is a risk of PEM, and Todd sort of outlined now the research says half half of patients have a long recovery of 3 weeks or longer, and half the patients have a quick recovery of less than a week. And I tell patients you should know what your recovery trajectory is when you overdo activities or exercise and to plan for that. If that's an acceptable risk, then maybe the benefits outweigh the risk. And the benefits of having a disability check, having medical insurance because you're disabled may outweigh the risks. No one is ever forced to do this test. Everyone signs an informed consent that they understand the risks, they understand the potential PEM, And if they're willing to accept that risk, they sign the informed consent and understand that is a risk they're willing to take.
Thank you for detailing that. Because a lot of people, it may not be appropriate or, depending on the situation, really. And how do
Yeah,
you help support patients? One thing you said recovery. When you say recovery, do you mean like back to their baseline from before the test?
exactly, exactly. So where you come to before you have the CPET, that's your baseline. And then we want to get you back to that pre-test baseline.
What are some things that you do to support patients after the test to help them during that period when they're experiencing PEM?
Yeah, we have a list of preparation and recovery tips, things to do before the test, but things to really be mindful of. If you know you're going to be out of commission for a few days or weeks, to do meal prep ahead. Plan to get someone to take your kids to school. Do all of those things, get your support team in place to help you until you're back to your baseline. So plan for that. We also recommend IV saline. We've had patients undergo 2-day CPET. Uh, with a 3-week recovery, do IV saline, and then they're recovered, in 3 days. So for some patients, just that increase in electrolytes and fluids, there's something unique about IV saline versus oral rehydration that's really helpful for some patients. Athletes are using it to recover. And then we're looking at a whole host of PIM busting strategies, in addition to pacing and rest, of things patients can try. So we're looking at other options that can kind of act as rescue strategies.
Thank you. And Todd, I wanted to ask you, are there alternatives or other tests that can help document for someone's functional impairment?
There are several different tests that we try and use, but that the problem is that they're only done on a single test basis. And anything done on a single test basis runs the risk of inducing post-exertional malaise, and then not capturing the functional effects of it. And so, again, for disability hearings, someone can be completely normal on a 6-minute walk test or a 3-minute stand test, or can test out, age appropriate for their hand grip test. But if we never come back and test again in the post-exertional state, and we can't really demonstrate the functional disability. So, yeah, I think it's a really good point that we should just believe patients. And I think if we could just stop there, then we wouldn't need to do any of this. And there's no doubt about that. But the problem is that nobody believes patients. Very few people believe patients, especially not insurance companies here in the U.S. And so we are sort of left with this. In addition, I would say, um, the biological characterization of the illness and research still merits consideration here. It would be nice to start moving off of 2-day CPET and onto a different test, but there's just none that have been validated for purpose yet, which is something that we're working on doing.
Yeah, it's interesting. I had a patient who underwent a functional capacity evaluation, and they did a 2-day functional capacity evaluation, and it was, in reading the report, it was a super long test with 4 hours each time of grip strength, of walking, all these different things. And then the next day did it again. And I thought, whoa, 8 to 10 minutes on a bike to show the post-exertional malaise is better than the 4 hours each day going in. I don't know why they're starting to do a 2-day functional evaluation for 4 hours each time. That seems awful.
Yeah. Well,
Um,
and Clayton, to your point, there are functional capacity assessments like that. There are neuropsych evaluations and 2-day neuropsychs. And I've had a number of patients tell me that those tests of multiple hours are so much more exhausting than the 2-day CPET. And just to give, for those of you that haven't undergone it, it's unloaded cycling. It starts with just the weight of your legs. And it's hard to keep up with the bike. You don't feel the resistance until you get to 30 watts of work. And typically, that's for 2 minutes. You don't even catch up to the workload. It's only really hard for a couple of minutes, and then the test is done. So while it is maximal and it's hard for the last couple of minutes, it really is interesting because that anaerobic threshold can identify when you need to stop. And so for the majority of our patients, they're living their lives over their anaerobic threshold, causing rolling PEM all of the time, and they don't know when to stop. When doing a 2-day CPET can give them that information to pace the rest of their lives and avoid that post-exertional malaise. So the example that I like to use is a maximal CPET is the equivalent of walking up 2 flights of stairs carrying a bag of groceries. That's the metabolic equivalent. And so I think for most of our patients, just living their lives, they're almost hitting the same level of exertion that they would hit in a max CPET.
Yeah, I've undergone the CPET myself to feel what
Mhm.
it feels like. And the first part is just your legs are moving, but there's no resistance. And it's
Yeah,
not until the very last minute or two that you start to get short of breath and notice that it's getting more challenging.
right.
So we have some questions in the chat I wanted to go over. One is, let's see, doing a 1 day CPET, y'all mentioned, doesn't really capture the impairment. So someone mentioned that their VO2 is normal with a 1 day, and that's hard. It doesn't really show with a 1 day. Is that correct?
We started with a 1-day CPET, and we really wanted to show PIM with a 1-day CPET, and it does cause PIM, but without objectively measuring the metabolic and the cardiovascular and the pulmonary function on day 2, we couldn't find anything that captured it well. And we've tried a lot of things. We tried reaction time testing and acoustic nasal rhinometry and I mean, on and on and on. We tried all these things pre-post to capture that PIM, and the CPET was the only thing that really captured it consistently.
And have you seen a difference between patients who have ME/CFS from before COVID and those who have long COVID ME? Have you noticed a change in their results?
Todd, you want to share the paper we just published?
Yeah, we just published a paper indicating that we see a lot of the same results in pre and post-COVID ME. And those same results are, similar some similarities between ME patients with ME and patients with post-COVID ME at maximal and submaximal levels of exertion. But it's the submaximal levels of exertion that are the most striking findings, because what happens is that the volume of oxygen that your body can use decreases at what we call the anaerobic threshold on the second day of a 2-day CPET. And what that means is that you're physically capable of doing less. Think of your anaerobic threshold as the amount of physical activity you can do, or the level of physical activity you can do without losing your breath. And so people don't like to function over their anaerobic threshold for very long because you lose your breath and it's uncomfortable and so forth. So if your anaerobic threshold decreases on that second day, it's like your ceiling has crashed, along with the rest of you feeling crashed. So your metabolism has crashed, and so you literally cannot do what you did the first day. And we see the very similar pattern in post-COVID ME as we did with pre-COVID ME, and it's not explained by some differences in heart rate responses to exercise or respiratory rates to responses to exercise. And so it does seem to be a bioenergetic abnormality.
Great, thank you. And Stacy, does 2 day CPET miss post-exertional malaise that doesn't kick in until 48 hours later?
Such a
Or,
good question.
yeah.
I think that every patient that comes to see us is worried. They're worried the test won't show anything. And I would say for 98% of our patients that have PEM, we show abnormalities. And that's the number one question people have. They have no tests that show anything wrong, and they're worried that the 2-day CPET will not. And rarely is that the case. Now, we occasionally have patients whose PEM doesn't kick in for like 2 or 3 days. And probably only a handful of times we've done a 2-day CPET and their PEM has not yet kicked in. And so we'll bring them back that second or third day because the idea is to catch the person when they're in PEM. And 90% of the time, we're able to do that within 24 hours. Even if PEM hasn't fully kicked in, it's beginning to manifest. Uh, We've also had an occasion where the equipment didn't work well on the second day, and so we had to bring somebody back for a second and even a third day. And what happened was their anaerobic threshold, their workload at their anaerobic threshold was 75 watts on day one, dropped to 50 watts on day two, and kept dropping. So if we kept bringing somebody back 3 or 4 or 5 or 6 days in a row, this is what would happen. Now, ethically, we don't want to do that to anyone, but we only do it when there are extreme circumstances. We didn't capture the PEM and the patient requests it, or for some reason there was an equipment malfunction. But that's what we've seen, which is pretty remarkable.
Yeah, that really shows that pushing through the symptoms does not help, or graded exercise is just going to make
Oh,
things worse.
the worst thing you can do. And I think that's the other validating piece is that if your aerobic energy system is broken, you cannot exercise your way out of it. You will make yourself worse. And, if you have this constant flare up of symptoms in PIM, it's an inflammatory response, and you'll just keep getting sicker and sicker and sicker.
Yeah, when I recently presented to a group of doctors and I shared this, don't push through your symptoms. You need to listen to your body, and that's what we instruct patients. One of the doctors said, well, that's great and all, but sometimes you have to tell patients you need to exercise, you need to push through. And I was like, oh, how? No, we have research showing that does not help. Um, is the CPET able to also exclude other comorbid conditions that might be contributing?
Well, it both includes and excludes. So we look at each system and see if it's performing normally or abnormally. For example, over the years, we have actually identified undiagnosed cardiac disease. We had a patient with a congenital heart problem that they didn't know about. And we sent our report back to their doctor, said, please follow up with your physician. And they found, unidentified heart disease or lung disease or autonomic dysfunction, which now, we didn't even know about that 20 years ago. And now it's so common, orthostatic intolerance, and yet still undiagnosed frequently. And there are indications on CPET that indicate follow-up should be done.
Yeah, we've had some discussions about your new research that you've been doing showing that during post-exertional malaise, there's a drop in blood flow to the brain as well. And even when the person's laying down, is that right? Can you go into more detail about that?
Yeah, Todd, you want to share that case study that we published?
Yeah, so we published a case study suggesting that in the post-exertional state that there is a reduction in blood flow to the head, and so this might be related to the systemic response associated with the bioenergetic failure to recover. And so again, this points to not we so I Staci and I are kind of mitochondriacs and we're CPET nerds, but we do recognize that this is a multisystemic disease. And one of the things that as physiologists we always try and do is try and figure out in a complex system what leads and what follows. And one of the things that might be following this bioenergetic failure is a systemic collapse of sort of circulatory support through perhaps a reduction in autonomic tone, that fight, flight, or freeze tone that should be helping to squeeze the diameter of your blood vessels in order to keep blood going to your brain doesn't seem to be working as the same in the post-exertional state as it did.
Thank you for touching on that. Since we're on the topic of orthostatic intolerance and POTS, someone asked if you have POTS and are taking a beta blocker, will that skew the measurements or make them unreliable during the CPET?
Well, they're not unreliable. They're just it depends on how the beta blocker affects you. So the interesting thing is we've tested a ton of people on beta blockers and they have a normal heart rate response. So that always makes me go, that's interesting. Um, it depends on how much the beta blocker blunts. And it tends to blunt at the higher end of heart rate and not as much at the lower end. And for heart rate monitoring, it does make it difficult. We always put a note in our reports that certain medications may blunt heart rate responses if there is a blunted response. And we often see without medications, especially in PEM, there's a blunted heart rate response. So certain medications we know cause a blunted heart rate. And know that if you're trying to use heart rate for pacing and you're on a beta blocker, that can be problematic. So it's really helpful the timing of the medication, the type of medication, knowing how much it blunts heart rate, if it's blunting your resting heart rate, if it's blunting that heart rate at threshold. Todd, do you have suggestions there as well? That's always a number one question we get.
Yeah, it's a big question that I get clinically as a physical therapist in terms of, trying to use heart rate to pace. And ultimately you certainly can use heart rate to pace because as Stacy mentioned, the heart rate response to activity is strikingly normal, even though people are taking the medication, which so sometimes you wonder about the medication. But beyond that, the heart rate response tends to be more blunted above that anaerobic threshold, which is with pacing, we're trying to sort of keep people below that anaerobic threshold to keep them out of oxygen debt, essentially. Um, and so you can still use heart rate based pacing. It may be that some additional kind of deeper reflection, symptom journaling, and so forth is important because there may be a disconnect between heart rate and signs and symptoms. We might need to kind of figure out, start with a heart rate and titrate it from there in terms of the specific effect that you're having from the beta blocker. But yeah, so there's some nuance there.
Okay. And that's helpful to understand situationally if someone's on certain medications, how it would affect. One question we get asked a lot, and both when you've presented to physicians as well, is everybody wants to know where if where would one go to get a test like this? Often I've heard patients say their doctor said, "Oh, we could do it," or um, people will say that they can do it, but the problem is that they may not interpret the results or have accurate testing. Is that right?
Yeah, it's you sort of have to go to a place that does this type of CPET. And what I mean by this is that you can't walk into any cardiologist's office and get this done. Most cardiology offices will put you on a bike or a treadmill hooked up to the EKG. They'll watch your heart. They'll estimate how far you can go. They'll do a single test. They'll make sure that your rate and rhythm are normal on the EKG, and then send you on your way. So this is a very different test. You want to make sure that you're going to a place that does CPET for diagnostic purposes through gas exchange, where you're breathing into the tube, with the mask in the tube, into the computer. That's the first piece. And then the second piece is you want to make sure that computer is calibrated frequently because it tends to fall out of line. So you do have to make sure that it's adjusted frequently. And so you'll want to use the magic words biological validation. Do you use biological validation, which means do you have someone who performs at a certain level, hop on that apparatus and make sure that apparatus is measuring at the level that you would expect within a percent or two. And if the answer to both of those questions is no, or if answer to either of those questions is no, you know that that's not the place that you want to go to get your CPETs done.
And they need to have experience with ME and long COVID in
Yes.
interpretation. So typically, we all view this test through our own lens. So if you go to cardiologists, they'll look at your heart and say you're normal. And if you go to a pulmonologist, they'll look at your lungs. And if your lungs are normal, they'll say your test is normal. The danger is that that gets put in your medical record when your CPET results may not be interpreted for function and for disability, and your oxygen consumption may actually uh, report or support that you're severely functionally impaired, which is what disability and Social Security and long-term disability needs to know. Can you work day in and day out? And typically, cardiologists and pulmonologists really aren't trained in disability evaluation. They're looking at diagnosing heart and lung problems.
Yeah, that interpretation is so important because if you just go to anybody, get a 2-day CPET, they can say they do it, but if they can't interpret it and they don't understand ME, that's not going to be helpful.
Or even worse, I've seen reports where they do 2-day CPET and then recommend exercise.
Oh,
So they completely miss, like, there's a decline, and they're like, just go exercise aerobically and you'll be fine. That's the last thing you want in your medical record. So
yeah,
clearly a lack of understanding, but with good intentions. Everybody has good intentions. They want to help. That doesn't
yeah.
mean they can.
One of the issues I've heard about the test is that often more mild or moderately ill patients will get the test to justify disability, but then some of the more severe, very severe patients don't have access to it because they're just not able to tolerate that. And so it kind of makes it where the people who are mild to moderate might have a better case, whereas someone who's more severe, it's harder because they can't have that objective proof. And then disability companies may start wanting more of the testing for everyone, even if there's patients who don't tolerate it. How do you address those concerns about the testing?
Well, disability companies don't want you to have the test because it proves you're disabled and then they'll have to pay the claim. So that's never a concern. Um, this is a really interesting question. I think you have to be able to walk. You have to be able to ride a bike and give a good effort to even consider doing the test. That said, the majority of the patients we see are in the moderate to severe functional impairment category, and the categories we use are for circulatory and heart failure. So our patients aren't none to mild. They are showing severe impairment. The people that typically do this test are people that are going to die without a heart transplant. And I think that's what the people in our community don't understand is that this test is done for people who are dying, who are going to receive a transplant, and they do a CPET to see if they will survive. That's what this testing is used for. It's used in people who have severe heart attacks, who have severe lung disease, right? These people are all very severely impaired, and the impairment doesn't matter regardless of the illness. The most severe bedbound patients won't be able to walk and won't be able to do this test. I would call those very severe. But the patients that we've seen over the years, they're in the severe category. They're in the moderate category. We occasionally see some mild, but rarely actually. That's that's a small percentage of our patients. Our patients have PEM. They're moderate to severe.
Okay, that's
And
helpful to know.
it's a patient's choice to do this. Again, we are offering a service, but we are not requiring that anyone that feels like they can't do it. If you don't feel like you can do this or want to do this, this is a service that we offer to provide validation and disability, but it's not required for anyone. No one should feel pressured.
Yeah, that makes sense. Do you notice, back to measuring things, do you also look at lactate? do lactate measurements? That's what one of the questions is from the first day to the second day, or if that's helpful or not.
There are a couple studies out there that have looked at lactates in this population, and good for them. I'm glad. Blood is hard on the patient. It's messy. Lactates are a little hard to analyze and make sense out of. And so what we know is that there are two different ways to measure when you're in anaerobic threshold. You either exceed a certain amount of lactic acid or lactate in your body, or you can change the composition of your breath to basically favor more carbon dioxide than oxygen. Um, we like measuring breath because it's less messy, it's easier on the patient, and those two measurements are correlated very strongly. And so we feel very comfortable that identifying where, again, that carbon dioxide composition in your breath increases out of scale with the oxygen composition in your breath is the same thing as the lactate threshold. So, maybe the lactate is a little more direct measure of anaerobic threshold, but we're very comfortable with the reliability and the validity of this methodology, which incidentally is used by labs and clinics all over the world every day, and so it's sort of time tested as well as valid in terms of the research.
And I would just add that we've done it. We've done lactate and glucose measures and found nothing helpful. And the NIH study also did it. It involves either finger sticks or art lines. It's not fun. It hurts, and it's one more stress on the patient. So I'll use a Todd phrase, the juice isn't worth the squeeze. So if we can prevent, we don't like the invasive stuff. If we don't have to stick you, we don't want to. And, a lactate balance point study, or if you want to do a lactate study to get a lactate threshold, you got to stick somebody repeatedly throughout the entire test over 2 days. And you don't have enough fingers after a while. It's a lot of sticks. I've done it and it's not fun. So I don't want to do that to anybody else.
Yeah, that makes sense to minimize all the other
Yeah.
things you're measuring. I've seen some studies recently being put out for measuring the effect of exercise for POTS or other conditions, and I've seen that they want a lot of data, and it's really exhaustive versus trying to minimize and see what's most important. So, looking ahead, how do you see the role of 2-day CPET evolving, or what do you see its use for research and finding things that will help with post-exertional malaise recovery or prevention?
Well, I mean, the 2-day CPET is probably the most consistent biological evidence of post-exertional malaise that we have, as imperfect as the test is. Um, and we can still use the test in order to determine whether certain medications, strategies have an ability to ameliorate that response that we see consistently, which is, the reduction in volume of oxygen consumed and workload at the anaerobic threshold, as well as the recovery time after a standardized physical stressor. So it's still very much an important research paradigm to test any number of different drugs, and I think it's been underused in this space. Now, as for the future, 2-day CPET, I think still is a reasonable tool to validate other types of tools against. One of them that we're excited about right now is the idea of trying to capture metabolic reflex. Metabolic reflex, essentially, if you think of CPET as taking the system to the limit, the metabolic reflex is sort of the opposite. It's trying to detect the earliest onset of cardiovascular change in response to some of the circulating waste products associated with exercising. So this is standardizing a hand grip task. And we think that this will help to improve inclusion of individuals in the severe to very severe range, giving them a way to sort of objectify and validate to the outside world their disability as well. Staci?
I think the major missing piece, and I saw one of the questions in the chat is, does CPET measure cognitive PEM? And that's the one thing it doesn't do. And so I'm really optimistic about looking at using Lumia to measure blood flow to the head as a measure for cognitive PEM and a potential explanation. And so I'm really excited about that's sort of the next step for us in looking at both the physiological measures from CPET and then pairing them with blood flow to the head to see if that signal is consistent. And that could answer a lot of questions.
Yeah, exciting research coming. Thank you so much for answering the questions. We'll try to respond to some of the questions in the Q&A via email afterwards, but thank you so much for joining us, Todd and Staci, and we hope to see everyone again for our next session on Wednesday, June 10th at 10 a.m., where we'll discuss management of post-exertional malaise, so some strategies and tips for better managing PEM. And we'll send an email with the recording and associated resources at the end of the month to those who've subscribed to BHC emails. And please complete the brief survey that will pop up on your screen. And I look forward to being with you next month. All right, we'll see ya.
Thank you.